Yeah, thank you, madam. Good afternoon, dear sir, madam, and my dear colleagues. First of all, I would like to thank Sri Lankan College of Dermatologists for giving me this great opportunity. Today, I'm going to discuss about antifungals in special situations because in Sri Lanka, currently we don't have guidelines for antifungal treatment. British Association of Dermatologists as well as American Academy of Dermatologists, they are giving separate sets of guidelines for the management of onychomycosis as sometimes tinea capitis. But for special situations, usually we need to find it out. Next slide, please. Yes. Epidemiology wise, fungal infections of the skin and nails are a common global problem. Yes, superficial fungal infections account for nearly 25% of global skin mycosis. And dermatophytic infections, one of the most common types of infective diseases worldwide. It's a major public health problem around the globe, causes considerable morbidity, and also it continues to increase, especially in developing countries like our country. Yes, the prevalence. The prevalence is rising in dermatophytosis in tropics as well as in the world. Most of the time, we are getting patients with widespread illness, as well as sometimes whole family has been infected, sometimes whole village has been infected by the same illness. And also, nowadays we come across increase in resistance to drugs even. In that case, I think it needs special attention for dermatophytic infections. Yes, this is the family of fungal family. Large family consisting of yeast dimorphic fungi as well as molds. But today I am concentrating mainly on dermatophytic infections. Next slide. Yes, pathogens could be anthropophilic as well as zoophilic. Genera-wise, it could be trichophyton, microsporum, or epididophyton. Appearances varies considerably inter as well as intracontinentally and globally. Next. There's variety of topical as well as systemic agents available. Uh, and also the treatment could be monotherapy, combined therapy, even sequential therapy. Not only the pharmacological methods, but also general measures are very important, especially to our country. Loosely fitting clothing and avoid synthetic clothing and need to change clothing more frequently and avoid sharing garments and towels. Undergarments, socks, and caps should be thoroughly washed and dried out. And patients with tinea cruris as well as tinea pedis may be assessed for underlying conditions like hyperhidrosis, obesity. And also they can use absorbent powders like clotrimazole powders. Next. Yes, just to give a brief idea about mechanisms of actions. All our drugs can act on cell wall, for example, caspofungin, micafungin, as well as cell membrane, which inhibits the ergosterol, a molecule unique to fungi. Groups are azoles, it could be imidazoles like ketoconazole, and triazoles like fluconazole and itraconazole. Both these drugs are fungistatic most of the time, but with high dose, it could be fungicidal even. And all this group acts on cytochrome P450 system, but imidazoles and triazoles have different inhibitory effects on P450. And other drugs in this group are leelamines like terbinafine and cyclopyroxalamine, and as well as other drugs like nystatin and amphotericin B. Regarding the amphotericin B, we are mainly using for systemic illnesses. We have conventional amphotericin B as well as three lipid formulations like liposomal, lipid complex, cholesterol complex. They are less nephrotoxic but cost-wise very expensive. Other drugs act on intracellularly like fluoxetine, pyrimidine analogs, and also griseofulvin that inhibits microspindle formation. And griseofulvin is again it's a fungistatic drug, acts on trichophyton, microsporum, as well as epididophyton, but doesn't act against yeast, including Malassezia and dimorphic fungi like Cryptococcus. Regarding these all drugs, antifungals, not only the antifungal action, they all have anti-inhibitory action as well. For example, azoles will inhibit neutrophil chemotaxis, inhibition of prostaglandin, and so on. Next. Oral antifungals. Since 2008, there have not been additions to the oral antifungals. Terbinafine, itraconazole, and fluconazole still in widespread use. Griseofulvin is used in the treatment of tinea capitis. Oral ketoconazole has fallen out due to the severe hepatotoxicity. Next. This is the normal treatment regime for a healthy adult. Next. Regarding topical antifungals, normally topical azoles like miconazole primarily treating for mild cases. And also we have not only the old topical therapy, we have newer topical agents like eviconazole, again azole drug, luliconazole, sertaconazole, oxaborole, as well as tauberol, which is in which inhibits essential fungal enzyme leucyl tRNA synthetase. And also we have amarolfin that is also available in Sri Lanka even. Almost all these newer topical agents are addressing mainly onychomycosis. And research focused on developing formulations of existing topical treatment that utilize novel delivery systems. Next. Antifungals in special situation. First, I will discuss about specific patient groups like elderly, children, pregnant women and lactating mothers, and immunosuppressive patients. Next. Elderly. This is the next. Newer working classification for elderly patient is 60 or 65. Next. Concerns in elderly. Slow metabolism of the drug due to aging liver and kidneys. Reduction of serum albumin levels leading to increased concentration of unbound drug. And systemic comorbidities like renal or hepatic dysfunction and cardiac diseases. And also drug interactions due to polypharmacy. And treatments in elderly. Treatment of tinea in elderly patients must be individualized. In addition, other factors need to consider like site and extent of involvement, organisms found in cultures, and availability of the drugs as well as the cost. A healthy elderly patient can be treated as per recommendations applied to a young adult. Topical therapy for elderly patients with a single skin lesion and multiple comorbidities on polypharmacy, topical therapy alone can be administered. A Cochrane review observed topical 1% terbinafine is more efficacious with few adverse effects than topical azoles. Coming to the systemic therapy for elderly patients. Indications for systemic therapy. Tinea involving two or more areas simultaneously. Tinea corporis with extensive involvement. Tinea pedis, particularly Mocasian-novesicular type. Repeated failure of treatments with different topical agents. Next. Shorter duration of therapy with efficient antifungal agents is ideal. Terbinafine is more rational than azoles in an elderly patients who are on other drugs due to clinically insignificant drug interactions. Itraconazole is better avoided in patients on other drugs metabolized by cytochrome P450 system. And griseofulvin is not recommended due to low cure rates, high relapse rate, as well as poorly prolonged daily dosage regime. So, a healthy elderly patient can be treated as per recommendations applied to a young adult. Systemic drugs like itraconazole, fluconazole can cause multiple drug interactions. In that case, terbinafine is preferred. Next, renal diseases in elderly. T-half, the terminal half-life of terbinafine and fluconazole increase in patients with renal impairment. In that case, if patient's creatinine clearance is less than 50, dose need to be halved. Liver diseases in elderly. In the absence of pre-existing liver disease, rate of liver injury was less. Pre-existing liver disease is a strong risk factor for the development of drug-induced liver damage. Both itraconazole and terbinafine can cause acute liver failure in patients with hepatic impairment, mainly itraconazole. Fluconazole and itraconazole are both cytochrome P450 inhibitors, can cause multiple drug interactions, but fluconazole may be used with caution. Most of our patients are having dyslipidemia and on statins. In those patients, itraconazole has been reported to have precipitated rhabdomyolysis in a patient on long-term statins. Liver disease is common with voriconazole and posaconazole, even without existing liver injury. Griseofulvin is not indicated in patients with hepatic failure. Coming to cardiac diseases, itraconazole is has a negative inotropic action on cardiac muscles, leading to decreased cardiac contractility. And also it will prolong QT interval as well as torsade points, ventricular tachycardia, cardiac arrest, and even sudden death. Next. In that case, itraconazole should not be administered in ventricular dysfunction, congestive cardiac failure, or history of congestive cardiac failure, and also proarrhythmic conditions. Need to stop itraconazole administration if patient develops symptoms of congestive cardiac failure. In addition, co-administration of macrolides, cisapride, pimoside, and quinidine is contraindicated due to prolonged QT. Children. Next specific group is children, and in that group, cutaneous tinea is relatively less common than tinea capitis. The treatment of cutaneous tinea in children generally limited to topical antifungals and normally gives good results due to rapid turnover of skin. Topical therapy, as like in adults, no difference. Imidazoles in same concentration we can use, and also 1% terbinafine, cyclopiloxolamine, and also Whitfield ointment, that is combined 6% benzoic acid and 3% salicylic acid can use. Normally 2 to 4 weeks need to continue, and they have to apply at least 1 centimeter beyond the active margin and need to continue for 2 weeks after resolution of the illness. And topical agents mixed with corticosteroids should be avoided. Systemic treatment. Clinical studies in children are limited, but they suggest fluconazole, itraconazole, griseofulvin, and terbinafine all are effective. Oral griseofulvin and terbinafine, both well tolerated, no clinically relevant derangement of liver functions. But especially for the tinea capitis, they require longer duration of therapy. Next. Trichophyid and tonsurates, terbinafine is more better than griseofulvin. And for the microsporum variant, griseofulvin is better. Griseofulvin, the mycological and clinical cure rates in children is between 88% to 100%. And there's microsized and ultra microsized formulations designed to reduce GI upsets and to optimize the absorption. Currently, we have 500 milligram tablets, but even in children, we don't have suspensions. Next. Terbinafine can give terbinafine for tinea capitis in children 2 years of old, 2 years of age or older, but it's less efficacious for ectotrichs due to lack of penetration into eccrine sweat glands as well as low levels of sebum before the puberty. Itraconazole, like in adults, we can give continuous as well as pulse therapy. It's safe as well as well tolerated. Because of the minimal relapse, makes it a better alternative to glycerin in children. Also, the capsules can be opened and the beads placed in semi-solid food for dose adjustment. Fluconazole, oral fluconazole once weekly, normally 5 milligrams per kg, 6 milligrams per kg dose, weekly for 8 weeks is effective in children in the treatment of tinea capitis. So, Indian guidelines recommend fluconazole, itraconazole, terbinafine, and glycerin can be used in pediatric age group. Terbinafine is recommended only after 2 years of age. Fluconazole can be used during the infancy as well. Normal dose is 5 milligrams per kg per day, but at least for 25 days. Next. Next specific group is pregnancy and lactation. Pregnancy is a physiological condition prone to infections, especially fungal infections. And drug administration during pregnancy, we need to consider about 2 individuals. Fetal adverse effects. Teratogenicity is most likely occurs during the first trimester. And second and third trimester, growth retardation, respiratory problems, infections, and even bleeding can occur. General measures are important in pregnancy and lactation as well, especially in our country with a tropical country like our country. And need to avoid sharing of towels and clothes, avoid tight clothing, and they can also use absorbent antifungal dusting powders. And onychomycosis treatment may be attempted after lactation is stopped because most of the time it requires systemic therapy for longer duration. Topical therapy in general can considered safe because due to negligible systemic absorption. Topical antifungals, mainly azoles, minimally or not absorbed systemically, can be prescribed at any stage of pregnancy, like in others, twice daily till the lesion subsides and continued for up to 2 weeks. But terbinafine and cyclopilox, more limited data available. And also over-the-counter products in pregnancy, Whitfield ointment can use if benefits outweigh the risk because there's risk of absorption of salicylic acid. Castellani paint, it's not commonly used and also no documented risk of using in pregnancy and lactation as well as no large-scale studies to assess the risk. Systemic antifungals in pregnancy, little data exists regarding the safety and of these drugs. Glycerin need to avoid due to limited safety data. Fluconazole and itraconazole, especially during the first trimester, cardiovascular, skeletal, craniofacial, and neurodevelopmental defects can occur. In addition, estrogen and testosterone production will be affected. And also fluconazole and itraconazole are embryotoxic and terotoxic in rodents. In that case, contraindicated throughout the pregnancy. Next. Terbinafine, categorized in category B, data on its use in pregnancy is not present. Even though whether terbinafine crosses the placental barrier is unknown, they recommend terbinafine use after first trimester is reasonably safe. Next specific group is immunocompromised host, for example, hematopoietic stem cell and solid organ transplants, neutropenic patients, patients with acute leukemia and other malignant diseases, and also other diseases like HIV. This group usually present with systemic infections like candidiasis mainly, next to that aspergillosis and so on. But extensive dermatophytic infections percentages I couldn't found. Next. The majority of infections occur more than 90 days after transplantation. And the occurrence of early infections, that means less than 90 days, is dominated by invasive candidiasis and invasive aspergillosis. Significant number occurs beyond 3 years after transplantation. So if the patient is non-neutropenic with candidemia, fluconazole is the drug of choice and alternative is icosapent. Next. And if the patient is neutropenic, presenting with candidemia, then the drug of choice is icosapent and alternative is fluconazole. Next. HIV infected patients and antifungals. They are present with systemic fungal infections mainly rather than extensive dermatophytic infections. Mucosal candidiasis remains the most common fungal disease. Next to that, cryptococcosis, aspergillosis, histoplasmosis, and other infections also they can present with. Treatment. Azoles except fluconazole has the greatest risk of two-way interactions with antiretroviral heart therapy due to the cytochrome P450 system involvement. But interactions between antiretroviral drugs and icosapent is much lower. Combination of tenofovir and amphotericin B should be used with caution due to renal impairment. Next. And also uh, can use antifungal prophylaxis in immunocompromised patients. All our systemic antifungal agents are using. Next. Tinea incognito. It's a mycotic infection of the skin that has been modified by improper use of steroids and other topical immunomodulators. Next. Then we need to stop corticosteroids abruptly, but in the setting of steroid-induced rosacea, need to withdraw in few days' time. The drug treatment is itraconazole, usually 100 to 200 milligram BD for a quite longer duration, 4 to 6 weeks. Coming to next specific group, dermatophytic resistance to antifungal drugs. This is the evolution of antifungal resistance starting from older drugs like amphotericin B to newer drugs like caspofungin, micafungin. Next. These are the possible mechanisms: drug efflux, drug detoxification, transcriptional modulation of kinase genes, fungal heat shock proteins, mutations affecting drug target genes, as well as structural elements influencing drug resistance. Prevention or control of antifungal resistance. Judicious use of antifungal agents is a must and need to avoid treatment with low-dose antifungal agents. Sometimes combination therapy using drugs with different mechanisms of action is needed. And also we need more and more surveillance studies to identify true nature of antifungal resistance. Combination with immunosuppressive drugs. Calcineurin is required for virulence and drug resistance in a diverse group of fungi. So combination of calcium and calcineurin inhibitors with known antifungal inhibit the growth of drug-resistant fungal strain. This is mainly they have tested for aspergillosis, not for the dermatophytic infections. Fungal heat shock protein inhibitors have potent synergistic antifungal activity in combination with azoles and icosapent. But due to toxic effects, the clinical usage is limited. Role of cytokines. In immunocompromised patients, antifungal agents can combine with cytokines like granulocyte monocyte colony stimulating factor. Next. Coming to next specific group, recalcitrant tinea infection. It could be relapse, that is, after 6 to 8 weeks of complete treatment regime, or recurrence, that means within 6 to 8 weeks of complete treatment regime, or a reinfection, persistent infection, or a chronic infection, that means persistence of infection for 6 months to 1 year like. Next. Next. Next slide. Yes. For the treatment, we can use single drug. We can continue on regular dosage for a longer duration. Or we can double the dose for conventional duration, strongly favored for terbinafine. Or else we can use combination therapy if there's no response at the end of 3 weeks. Fluconazole or itraconazole with terbinafine, or fluconazole or itraconazole with griseofulvin, or griseofulvin and terbinafine. Treatment of dermatophytosis in special population groups such as pregnant women, children, and elderly needs a cautious approach. Ample evidence of safety is available for oral antifungals in elderly, pregnancy, lactation, and children. However, in cases where systemic treatment is required, terbinafine is preferred. Immunocompromised patients need modified therapy, and judicious use of antifungal agents is needed to reduce antifungal resistance. And recalcitrant cases can be treated with single drug or combined regime. Tinea incognito, itraconazole is preferred. Next. And in the next slide, please. In the future, development of newer drugs or topical drug formulations with a depot effect may help reduce the duration of treatment required as well as recurrences. Thank you.